Shweta ma'am. Hello, Dr. Divya. Shweta ma'am, don't record it now itself. There is another 30 minutes to start.
Good afternoon, one and all. With great pleasure, I would like to start this webinar series with a quote. One of the hardest things in life is having words in your mind that you can't utter. Keeping this in mind, we had long hours of discussion to finally come up with this topic. And keeping in mind the World Stuttering Day also coming up. We all have learned in detail theories, analogies, everything about stuttering, even in our college days. But how much are we really applying to our clinics? And doing just one webinar would not justify this topic. So we planned a series. To continue this, I first welcome all our speakers, Dr. Santhosh sir, Dr. Pallavi Kelkar, Dr. Rakesh sir, and Divya Seth ma'am, Dr. Divya Seth. To continue this, learning all the sessions, from all these sessions, the videos would be uploaded soon on the Isha website. But wait, just doing webinar will not be enough. Through this panel discussion, we would like to learn and discuss how to apply the knowledge of these webinar to our practical use. I would like to invite Sanjeev sir to continue this and request all members to participate in panel discussion. Kindly put your queries and questions in the chat box and keep your mic mute through the webinar. Sanjeev sir, over to you, sir.
Thanks, Mrs. Disha. Good afternoon, everyone, and I welcome you all to our final session of Fluency Friday series. Hope this Fluency Friday series would have been helpful to all participants in updating them to different core concepts of fluency addressed by our expert speakers. And I extend my heartfelt thanks to all speakers because they tried to organize contents of their presentation to focus on private practicing SLPs. Hope you all know speech language pathology profession is rated among the top 10 professions globally, and I believe majority of them are private practicing SLPs. In my little but 25-year of experience doing private practice as audiologist and speech language pathologist, there were few observations, and I would like to have opinion from all of you how much you agree with it. I request all participants to type in the chat box with your responses, and I request Mrs. Disha to summarize them. Okay, let me begin with first question. It's about referral to speech language pathologist, and I request all of you to answer with the given options. A. Self-referral. B. Interprofessional referral. C. School teacher referral. Or D. All above but only after their own experiments. Because I know most of you are private practicing SLPs. So you will be having enough of your experience. From where do you get your maximum referrals?
I request all the participants to please answer in the chat box. So we're getting a very mixed reviews.
Okay.
Mostly going to D.
Okay. So it says the best possible option is actually taken at the last. Okay, moving on to second observation. I request again all of you to please respond. I do just clinical work. B. I do clinical work and administrative accounts, awareness and all works. at my clinic. I hope all of you have got long experience. So I feel it should not take much of time for you to answer.
Definitely, it has to be B.
Oh,
Mostly people are going with B, sir.
so this means speech language pathologists are multitaskers. So now moving on to third question. And the third question is, I have to design specific material for each patient. And the second is, assessment and therapy material is readily available.
As expected, sir, definitely A.
So this means uh, every private practicing speech language pathologist gears are always turning on. So they have to keep on changing their gears the moment they get a 6-year-old child. You never know the next patient you will be encountering. He will might be aphasic and you have to work with language aspects. Okay, it's going good. Moving on to the next question. How many of you find this situation when you get a call and they directly ask you what are the charges for speech therapy course? Do you get these sorts of call? I hope this reminds you, Babu Bhai, of one famous Bollywood movie. Actually, he was getting wrong calls, but I don't think you are getting wrong calls. You are getting calls at the right number, but messages like this.
Number is right, but the statement varies a lot. Mostly A, sir.
Okay, so this means, in my personal experience, I have found that I get a call, sir, आप therapy का क्या charge लेंगे? When I ask them, did you ever met me? They say no, हमने दिल्ली में दिखाया था, उन्होंने बोला है therapy होनी है. So it sounds like instead of looking for a speech therapist, they look for a tutor. So they know in 8th standard what all subjects need to be covered. Okay, moving on to the next question. Uh, can you guess what is the common problem in spite of all your explanation about speech disorder? And you come down to this situation where you have to answer. You will explain each and every theory of any disorder. They will ask you, that will all is fine. Sir, एक बार जीभ देख के बताइए कि कहीं टंग टाई तो नहीं है. So,
People are pouring in with A. But I
okay,
really wonder, do they get these kind of questions in institute as well? Because yes, private practitioner definitely face all these things.
yeah, it's a big question. Okay, can I move to next one, ma'am?
Yes, sir.
Okay, now we going more specific. This is something I will ask all of you. If you deal with only fluency clients, you deal with only pediatric or just the adult clients, or you deal with all speech, language, hearing clients.
So mostly everybody is going with C
Okay.
because
So actually, this particular question is very important for all of us because when we sit in our clinical rooms and when we have to face diverse population, so it becomes very difficult for us to get updated information on each and every disorder, and that is the sole idea why we organize these type of webinars. And this is the common one. I hope uh, what answer we can expect other than speech language pathologists. Everyone claims to give them 100% of treatment. and especially for stuttering problem, I believe. Is it? Is this answer is yes? Non-professionals claiming 100% treatment.
Yes, sir.
Okay, now coming down to our part, because the idea was initially we have seen our guest speakers talking about stammering. Uh, they explain each and every aspect related to stuttering disorder, but from private practicing speech language pathologists, we have got our perspective, how things we find challenging when we work in setups like a multi-specialty hospital or clinic. So now, with this, let's move on to bringing stuttering from book to clinics. And I invite all our guest speakers to come on our discussion table, and I'm going to put few questions on behalf of all the private practicing SLPs. And my first question is to Dr. Santhosh. Sir, I would like to know what do you feel, what is the need of standard stuttering assessment protocol?
Good afternoon, sir. Am I audible?
Yes, sir.
Yes,
Okay.
sir.
Okay, fine. So need, need not be emphasized because as you it's yourself you're saying it's a need, right? We need to have a standardized protocols across the clinics so that there is uniformity in the assessment, so that across clinicians there is some kind of agreement is there. So it is necessary. We need to have a standardized protocol, not just for stuttering, for all the communication disorders. Within stuttering, you need a protocol for children, for school-going children, for adults and adolescents. So there is definitely a need. It is necessary for to have a standardized protocol. Um,
Okay. Sir, my next question is, and I'm thankful to you that because on our request, you worked hard to design or format a standard stuttering protocol for assessment. And same thing had been, the request had been sent to Isha, and it is under consideration under their scientific committee, and soon all of us will be having access to it. But now I request Dr. Santosh to explain what all he has included in this standard assessment protocol, which he has formulated.
Okay. In the standard protocol which we have come up with as a team, means this we have already been put into use at AISH for my own doctoral students, their studies, as well as we use it in the clinic as well. So it starts with the detailed case history. We take a detailed demographic details about the child, parents, then with regard to child, what is the history with regard to development of speech and language, development of fluency, how did it start, when it started, what were the characteristics during at the onset of stuttering, and have the characteristics changed over the time, uh, from the onset to the current assessment. With regard to handedness, we collect information. Languages, we collect information in Indian context. Any triggering factor which has led to the development of stuttering, we tap on that. Uh, we also document the development of speech and language with respect to receptive, expressive language skills, phonological skills, especially because almost 40% of children who develop stuttering, they also have associated phonological disorder. So we document that in greater length. Um, so pedigree analysis is another important thing which we need to do when it comes to fluency assessment, because almost 60% of children who develop stuttering, they have a positive family history. So we need to document if anybody else in the family also has stuttering, if they have or had stuttering, how they are related to the child, and is it like immediate family members or distant family members, and have they had any kind of recovery from their stuttering also. That details also needs to be documented, because there are higher chances that if one of the family members who had stuttering and they have recovered from stuttering, even this child also has chances of recovering. So that needs to be documented. Once we do all these things, we also make sure that you take a history about treatment, if at all, before coming to you, if they have taken any kind of a treatment previously, how long was the treatment, and what is the gap between the current assessment and the past treatment. That needs to be documented. So that's about the case history part. Uh, Next we do is assessment of fluency. When it comes to assessing child, because during the early stages of stuttering, there is a lot of variability in the characteristics of stuttering. The way it is one day, it will not be same on the next day. So you need to tap that and document that. So it is preferable you record speech samples across different situations. I mentioned about during my presentation on assessment of stuttering as well, that at least 3 to 4 situations you need to be documenting, like parent-child interaction, narrative sample, picture description sample, clinician-child interaction, telephone conversation. Nowadays, most of the kids also they talk on the phone, so that can again be recorded. And minimum of 300 to 500 syllable sample has to be recorded, so that you are able to observe all the different types of disfluencies the child is exhibiting, adequately. Okay. Previously, we used to say that there should not be any kind of idea that child feels that his speech has been recorded. But I no more believe in that, because most of the children nowadays are familiarized with video recording and all the phone recording, and with mobile phones that has taken out, that awareness concept has been taken out. So they are more comfortable when it comes to recording and all those things. So you just make sure that you mount your camera in such a way that you are able to observe the secondary behaviors. So once you have the sample recorded, then the next task is analyzing the sample, and we suggest in the protocol percentage of syllables stuttered has to be measured, because syllable stuttered is more accurate than word stuttered, so that you can observe the multiple disfluencies within longer words as well. Percentage of syllables stuttered, I have talked about it in the presentation, is a very simple measure. Count how many syllables are in the samples, like 300 syllables, how many syllables are stuttered into 100. That will give you percentage of syllables stuttered. So as well as you measure the rate of speech of the child in terms of number or time taken to utter those many syllables. So you can say syllables per minute will be accurate way of documenting rate of speech. We also document naturalness. There are available common tools, freely available rating scales are there. You can just rate the speech naturalness of the child, and you can you can say whether the speech is unnatural or natural to you. To what extent it is unnatural to you? Mildly unnatural, extremely unnatural, like that. Okay. With these basic measures, we also suggest administration of SSI, Stuttering Severity Instrument. Currently, we have the 4th edition of SSI. We need to assess the severity of stuttering. So severity can be measured across different dimensions in SSI, like frequency, duration, and physical concomitants. So for children, you can do the non-readers with one, and document physical concomitants and duration of disfluencies. So you have separate tables for preschool children and school-going children and adults. So you can document the severity as mild stuttering, moderate stuttering, and severe stuttering. So this is enough for a clinic. If you have a clinic where you have the basic tools, like you have your own mobile phone which can be used, you have a SSI tool which can be referred from books, or you can download it from the online portals and all those things, and you can document the severity of stuttering. Uh, but this is not adequate to know all the aspects of stuttering. If possible, if you can, administer some protocols for assessment of attitudes, anxiety, it will be ideal in the clinic, so that if at all child has anxiety, increased anxiety, you can work on that. If child has any set of negative attitudes, you can, try to reduce those negative attitudes. So these are the standard ones which we have suggested in the protocol, which can be used commonly across the clinics.
Okay. So moving on the same lines, now I request Dr. Divya, Dr. Rakesh, and Dr. Pallavi, ma'am, what ready reference material we should have, which is appropriate to age, like while we are doing the assessment. So, sir is talking about the picture description task. So, in that case, like for different age groups, what type of material we should have as a ready reference? Dr. Divya, for preschool children.
Good afternoon, one and all. So, as Santhosh sir mentioned, yes, video recorder and standard tool is like SSI for calculating the severity. So, the fourth of SSI has normatives for preschool, school age, and adults. So, SSI 4 can be used for children who stutter. Now, when it comes to eliciting a speech sample, what should I have in my clinic so that I can elicit the speech sample? Preschool, now they are 3 to 6 year old, so they may not start talking as and when you ask them, or eliciting a monologue may be difficult. And when we try to have a conversation, most of the time the answers are single word utterances or maximum 2-word phrases, which is not sufficient to calculate the severity, or that a single word utterance response is not a good representation of stuttering severity. Okay, so please keep in mind that you need to elicit a sample where the child is talking in sentences. Now, how do you elicit? It has to be more of a play-based session for preschool age. So you should have some toys. Okay, the best way to elicit a longer speech sample would be to have something like a pretend play. Okay, so you play like a doctor and a patient, or a teacher and a student, or have puppets, finger puppets or hand puppets. Clinician has one and the client has the other. Cartoon characters. Now these days, a lot of children are very fond of Peppa Pig and all their characteristics, right? So you can become one character and the child can become the other, and have a conversation between those characters. So it's more of a play session, but that would help you to elicit a longer or sentence level utterances from a child. So that would give you a conversation sample. Other than that, reading is not possible for the preschool age considering their skills, but you can elicit monologue in terms of picture description or story narration. So you can have picture books, story books, where you have a park scene, a scene of a mall or something like that, and you ask the child to elaborate. Story narration, again, either you have picture book or picture card, or you can even show a story, a YouTube video or story, and ask the child to retell it, narrate it after they watch it. So that way, these are the ways you can elicit longer speech samples. Audio video recorded so that you can do the analysis. As already told, that it's best to do a percentage of syllable stuttered analysis and not percentage of words. So percentage of syllable is not possible when you are eliciting the sample. Online, you can't do it. You need to listen to the sample later and do it. And again, as private practitioners, you are the sole person there. You don't have a co-clinician who can sit on the side and do the calculation for you then and there. So you will be involved in eliciting the sample, playing or being involved with the child. So just audio, video record. And as Sir said, have the camera at a location where you can even record the secondary behaviors. So audio video recorder, SSI 4, and some toys for pretend play, picture description or story pictures. That is sufficient for a clinic. And if possible, then yes, some test or tools as mentioned earlier, OASIS is there for preschool children, Kitty Cat is there for preschool children. There are some parent perception scales available where what do parents think, how stuttering is affecting the child. So if you have access to these, even these can be included.
Now moving into Dr. Rakesh, what about the school-going children?
Good afternoon, sir. And In school age children, like most of it has been covered with the Santosh's talk only, as well as with Divya. The only difference between here with preschool and school age here is in school age children, the stuttering would have been already like it's there from 2 to 3 years, and they are well aware of the problem. And usually, eliciting response or eliciting speech sample from a school age child is not a difficult task because they would have been in schools and they would be speaking to other people and they usually talk. So the only one thing is we have to build a rapport with them and you should make them comfortable, the first thing. And second, whenever you ask for a monologue or a story narration, I recommend and request don't stick on to a standard story. Here we require a speech sample. It could be anything. It could be a movie thing, or it could be any Rambo or whatever movie, or a Tom and Jerry or Chota Bheem, whatever it is. What even though, and first thing is whichever story he can tell. Second thing is even though the semantics or the language is also not an issue, it could be anything, or if there are any grammatical errors, or it could the story could be like improper, he may not recollect properly. But here what we require is speech sample. So encourage him to talk. That is more than sufficient. If not, I usually say if they don't say that I don't have watched any movies, then a short note on a vacation. They would have gone to somewhere and Pravasa Kattana in Kannada we say, you please tell about it, narrate about it, a story narration on own experience. That will do for a monologue. And for reading tasks, and as they are school age children, they are like good at reading. I would suggest to go with their language of preference on the first day of assessment. If they require like mother tongue Kannada or English, it's up to them. And for reading tasks, basically, if they're not comfortable with our standard passage like Rainbow or anything, I would suggest to start reading from their own textbooks, school textbooks. So usually they are well aware, because sometimes what will happen under pressure or something will be going above them. Example, for a 6-year-old child, a rainbow passage could be more. So in order to avoid that floor effect or ceiling effect, I would rather suggest to go with the textbook because school curriculum would have made it age appropriately. So for reading material, a textbook will do, or an age appropriate reading material. Please make sure that. And second one is for a monologue, the story narration or movie or an own experience will do. And the third one is if you have any additional test material, SSI 4, percentage of syllabus status, these are all default. If you have an access to the additional test material, you can go with the regional specific normatives. For example, for Sir said for negative attitude, you can go for communication attitude test in school age children. If it is preschool, then it is kitty cat. If it is adults, then it is big cat. However, these test materials are standardized to Western population. In Indian language, we are trying to do it for Kannada. We have done it for big cat as well as cat, that is adult and school age. Kitty cat is under the pipeline. So we will be getting it. And for if you suspect any emotional reactions, like any increased speech related anxiety and all, you can go for speech situation checklist emotional reaction. That is there for school age population. Again, we are doing it for adults. So these are the additional test material that you have to know. The only one key aspect here is rapport building. Because as you know, they're school going children. If you make them that you are a friend, rather than saying that giving a pretension that you're a clinician or a doctor. So if you make them feel that you are a friend, then they will start opening up. And as Sir said, first session, they may not. Second and third, they will be unstoppable. Trust me, if you are really become a close friend. And once the treatment has started and the fluency has been induced, and it is a issue to just listen to them, they'll be keep on speaking. So only these things that need to be kept in mind. Other than that, everything is similar to adults and preschool.
Okay. Now moving on to another question, and that this question is to Dr. Pallavi. Ma'am, I would like to ask, like, whenever adult patient comes to us, he's so much involved with all his anxieties, and when he tried to explain his speech problem in the very first session, even if we want to get a clear picture of severity of his problem, he will be more talking about where all he had faced the problem. So his anxiety level is still very high. So would you suggest some sort of things which need to be used, which take him away from his emotions, and we get a clear picture of his severity of the problem?
Right. Before I start answering mine, can I add a little bit to what was said earlier, if I may?
Yeah, sure, ma'am. Please, ma'am.
Yeah. So about children, what Dr. Divya said about puppets, I just remembered hearing this speaker from the US saying this very nice idea that puppets can even be used to subtly understand if the child is aware or not of their stuttering. So, you can even make the puppets play and one of the puppets might stutter. And then you might ask the child which of them is you. So, without even trying to bring it up with the child, you can probably get to know if the child has understood that they stutter, or at least if they're aware that something is different about their speech. So that is one thing about puppets. The second thing, what Dr. Rakesh was saying was very very correct about the storytelling, that it should be a new story, and it can be anything. One thing which we should be noting while the child is telling a story also is language organization, because many times what might happen is that when we do a conventional language test, the child might tick the box when it comes to every grammatical marker, and we might say that the language is fine. But when it comes to organizing it in the form of a narrative, that is where many children might stumble, and that is what might also add to their disfluency. So if that is something that we notice, then we can work on it alongside working on disfluencies, and that really helps sometimes. So that was about children and like preschoolers and school going children. In adults, I might want to turn around the question a little bit, because when you said that while talking to them, how do we take them away from their anxiety and measure the severity? I would say the anxiety is very much a part and parcel of the severity. I would not, I would not term a person as a severe stutterer or a mild stutterer just based on his SSI score. I have seen patients who have mild or very mild stuttering and still have very high impact scores. So then do we call their stuttering mild or severe? So I would not in fact want to take them away from that anxiety. I would want to know more about that bit as well. That's the first thing. While assessing them, I am aware because I have been working both setups, private as well as academic. So I'm very aware that many times practitioners who have just started out might not even have the SSI score. So if that is the case, then what really helps is, like Dr. Santhosh said, measuring the percentage of syllables stuttered is absolutely essential. And one more thing that the SSI4 also doesn't look at is the types of disfluencies, which is like the SSI4 talks about stuttering like disfluencies together. But we should, I think, be documenting repetitions, prolongations, and silent blocks, because if we have a graph of that, then that also can help us tell the patient how he has progressed. Probably the entire frequency of disfluencies might not have drastically reduced, but now maybe he has less of hard blocks and more of just repetitions, which is great because his struggle has reduced. Okay, so documenting that is another very important thing in all age groups, preschoolers, children, and adults. And for attitudes and for one thing I would like to tell, because I'm sure there are students also here, many times students confuse between attitudes and impact. So please understand that attitudes is a subset of impact. Attitudes is just one part of the three concomitants of stuttering. And impact is everything. It is the core behaviors, it is the secondary, it is the attitudes, it's the environment, it is the person's own perceptions of all of these things. So ideally, if you have an impact assessment instrument, then great. We have the OSS is a standardized tool. We have the ISACs now, which is an Indian impact assessment instrument, but it is still in the process of being standardized. We have got data on 100 people who stutter. If you do not have any of these, at least measure attitudes. There are scales available freely online. One is the perceptions of stuttering inventory, which is very, very simple to take for the child, or even, I mean, if it's a school going or an adolescent child also, you can do it. And for an adult, so definitely you can do PSI. You can also, I like this tool called SSRSS, Stutterer Self Ratings of Reactions to Speech Situations. I like it mainly because A, it is available freely online. B, it has 4 profiles that we get. We get a profile of avoidance, reactions, stuttering, and frequency. Okay, so it tells us how much the person avoids any situation. It has 40 situations. How much the person avoids any situation, how much he, or he enjoys it on the other hand. So in reactions, we get to know how much he enjoys each situation. Stuttering, how much he stutters in it, and frequency, how frequently he encounters it. Okay, so this really gives us a very good profile for example, if you do the SSRSS before and you do it later, you might realize that the frequency of situations has gone up. So what does that tell you? That actually tells you that he stopped avoiding. He has started encountering these situations more because he goes and participates more. So although it is an attitude assessment instrument, it also tells you a little bit about participation. One negative about the SSRSS was that it was very obsolete. It was a very, very old tool, and it was obviously made with the Western population in mind. So recently, in 2017, it has been revised to make the SSRSS-I, which is the Indian version, and the statements have also been changed to suit the current cohort. And the tool is available with us at Bharati Vidyapeeth Pune. So I would be very happy to share it if anybody wants it. So these are all the instruments that I would recommend.
Okay, now moving on to next. This question is to Dr. Santhosh. Initially, and today also, you said that we need to have multiple sessions for stuttering assessment. But how feasible it is, the feasibility of the same in a private clinic? Like calling up a client three times just to give a diagnosis that he has got a fluency disorder. And as a matter of fact, the problem we face that whenever a client comes to us, on a very first day he asks us, आप हमें बता दो हमें करना क्या है. So how do you say about this multiple session feasibility in assessment?
Sir, because as you know, stuttering is quite variable. It needs to be documented when it comes to assessment of severity, especially with our own evidence from published study. We have found that someday it is mild, next day, like within a week, we have found it to be like varying from mild to severe. So it could be that when you did the assessment, the person is mild stuttering, but after 3 sessions of therapy, you find that the person is certain severity has increased to severe mode. So it should not be in a place where he starts blaming you. There is an increase in stuttering, right? So ideally, what we should be doing is, this is mentioned in Hegrede's protocol also. You dedicate one session for the assessment, half an hour session for the assessment, recording, and building a rapport with the client, orienting about speech therapy, what actually we do as speech therapists. That can be done. The next day, when next time when you call the person for therapy, you will be telling them counseling. That session can be dedicated for counseling. Whole session can be dedicated for counseling about what needs to be done, what are the myths about stuttering. As a clinician, what do you expect from him? It's not that you'll be only teaching the technique here, and whatever effort has to come, it has to come from the client side. These things have to be emphasized. So just before you do that counseling, the first 10 minutes again can be used for speech sample recording. You just need to record a spontaneous speech sample from the client, which is of 300 syllables. It doesn't take not more than 4 to 5 minutes. So just dedicate the first 10 minutes for speech sample recording. Same way, when you call the client third session for actual therapy beginning, just before the beginning of the therapy, record a speech sample, 10 minutes. So you already have 3 sessions of speech sample recorded with you. So in that way, by the time you start your therapy on the third session, you have done the counseling, which is the most important aspect of any therapy, and you have done the pre-therapy assessment with you. So you have 3 separate recordings, so you can observe the variability in the stuttering across 3 sessions, and you would know how much it is varying. So that way we can monitor for this variability in the stuttering.
Okay. My next question is, what are the do's and don'ts while we counsel for speech therapy option? On the very first day, we have done the assessment, or during few multiple sessions, we have done the assessment. So what are do's and don'ts? What all we need to share? What all we have to tell about the aspects of fluency?
Can I
Then we
revert
have,
this question, and I specifically we will see what all do's and don'ts for preschool children, for school-going children, and for adolescents and adults,
yeah,
because
yeah,
it cannot be the same for everyone. So maybe Divya, do you want to add on specific to preschool children? Rakesh will talk about school-going children, counseling child, teachers, as well as the parents for school-going children, and me and Pallavi can chip in and talk about what needs to be done with respect to adults and adolescents.
Yeah, sure, sir.
Divya.
Dr. Divya.
Yes. Yes. So do's and don'ts for preschool children, I would say they go hand in hand. With the assessment, and you have some idea about what is the severity of stuttering for the child. Most of the time, I start with my counseling by telling parents the probable cause of stuttering, because a lot of that is the first question they would ask, that why my child is stuttering. So based on the history, what you have collected, I usually go with the thing that stuttering factorial. So I do say that there are a lot of reasons, and based on the history, I highlight uh, that in your child. Hello, am I audible?
Yeah, please
Yeah.
continue, Dr. Divya.
Okay. Uh, yes. So I highlight what could be the possible cause, but more than that, I tell the parents that the cause, it's important that we now go ahead with the treatment. And I emphasize early intervention. So that's the first thing I emphasize to make them understand. I highlight the critical period and the sensitive period in a child's speech and language development. So I give simple examples that that it's a common notion that any new skill which a child is learning, the rate of learning is much faster at an early age. So you can give simple examples like, you put your child for swimming, or as possible, because they will learn it faster. Same thing goes with speech. So as early as possible, we need to start intervention. Then I explain them there are also advantages of early intervention. So a delay in treatment is directly proportional to the severity. So the more you delay, the more chances of the severity to increase. The more you delay, the recovery rate is going to be lesser. So if I start giving intervention right at the age of 3 years, when the child has been stuttering, say only for a month or two, they may recover completely if they complete the treatment program. But if you delay it and child is going to school age or adolescent, they may not completely recover out of stuttering. So that's the second. And third, the relapse rate. So if a child is attending early intervention as soon as the stuttering begins and completes the treatment program, then chances of relapse is much lower when compared to starting a late intervention. So that's how I justify the early intervention aspect. Also, I do tell them that, child is still in play school, so coming for sessions and all will not be a problem for you. Once the child enters school and has school morning 8 to 3 or 9 to 4, it becomes difficult for them to attend sessions also. So this is the right time before the child starts school. You can bring him, so that when the child enters school, the school timings, all those don't become issue. Plus teasing, bullying, all those social or psychosocial challenges which child may face at school, they also counsel them about the free they need to come. So I again
I feel there is some technical glitch from
Some
Dr.
internet
Divya's side.
issue.
We'll just wait, let her complete that so that.
Yeah, right.
treatment is what I suggest. So at home.
Divya, in between we missed you. Some last part of it we were not able to hear. Divya, thinks there is some network issue with her side. Rakesh.
Yeah.
Yes, sir. With counseling with do's and don'ts, sir. Before that, I would like to add on for one of the thing that for the previous question I missed out in the assessment of school age children. Here, during the interview, we will be observing the patient or the child informally. If there are any issues with the language or articulation or with hearing, then we will do a screening test, usually a KLT or a KAT or any screening test. And if the child fails, then we'll go for a detailed diagnostic test. If not, then we'll continue with our fluency assessment, because most of them do have comorbidities like misarticulation or language issues. That is one thing that I missed out from the previous one. And do's and don'ts with the counseling speech therapy option. Here's are the majorly like what Divya to, in order, just one thing I have to delete from hers when it comes to school age is early identification or intervention. Here already it would have been like 3 to 5 years is the age where most of them will get developmental stuttering. So the child would have passed that age. So already that time would have been elapsed. So I would say don't do this mistake in future, so that already you have waited. It could have been mild or it was very mild. Now it is in moderate. So if you still wait, it won't happen. The spontaneous recovery will not take place when the child is in school age. So the chances of spontaneous recovery is done. So in school age, the chances will be more to prevail. That is to have a sustained or a chronic stuttering. So just start therapy as soon as possible. Do not wait. That is one thing. And second, here I would like to involve the teacher, because what will happen in most of the time, as Divya rightly pointed out, in school, the teasing will start. Bullying, teasing, and all this unwanted psychosocial attention that will be given to the child. And so that the teacher is well aware of that and she can control. And one more thing is here, the child is not doing purposefully. The child is not doing to get attention, because most of the time what will happen, teacher will do that to get that sympathy the child is doing in order to get away from homework or get away from poor scholastic performance. Is doing that. The first point is the child is not doing voluntarily. It is an involuntary action, and please help out the child. If possible, make the child sit in the front bench or the second bench where the child is near to the teacher, where the teasing, bullying will not happen. And second is, when the teacher asks the child to stand up and read a textbook, that what we all do it in our school age children, give him more time. Don't pressurize him. And if somebody is mocking, if somebody is laughing at him, please control the peer group so that he will get more chance and confidence in order to speak loudly in front of everyone when he's going for therapy, and give the confidence. That is one thing. And second thing is scholastic performance. Some of the children with stuttering have poor scholastic performance. It is not like they fail, but they're below par. So for them, an extra attention is required. And whenever there is a oral or viva, so that time what will happen? The child might do good in theory, writing, but in practicals, when he's reciting or when there is a oral or a viva, he may not have that much of fluency. So he may not answer properly. So for that, give more extra time and be patient. Don't interrupt him between. So these are the do's and don'ts that we are going to involve the teacher also, with respect to the mother also. Here what will happen, if it is school age children, the scholastic peer pressure will be there. Like, you have to get first rank, you have to get 90% and above. This will not see much in the preschool age. It is like more of toddlers. But here they start comparing and they put pressure. Already the child will be in with more pressure, that there is a disfluency and everybody are looking at him. With this additional scholastic pressure, the problem of him ending up stuttering will be more. So I'll be counseling on those things also. And my last thing is early intervention. I know it's already been like we are past preschool age, but start immediately. Do not wait. And if you do not do doctor shopping, even though if you go for 10 SLPs, all 10 SLPs will say that you have stuttering and you have to start the treatment. And it should be, most of the time, it is behavioral therapy only. Like any other sort of medicine or any surgery will not help developmental stuttering. So please do not wait and waste the precious time. Start as soon as possible. These are some of the do's and don'ts that I counsel during my day-to-day activity. And one more, sir, last one is, there are so many students are here. So please explain what all tests did you do? What are the test results that was obtained? Most of the time I see observe clinician, they do all the speech sample analysis and they do the SSI-4 and all, and they straightly say you have moderate stuttering and you have to do this. Please take a time for 10 minutes and explain what are the tests and what are the results that were obtained, so that the patient is well aware. Even though if it is school age children or the parent, please explain that. Take a moment and do it. They will appreciate it. Thank you, sir.
Dr. Santhosh.
With regard to adults, Pallavi, do you want to first talk about it?
Yeah, about firstly about adolescents, I would like to mention a few things. One thing that I've noticed that is very important with adolescents, especially like more the older the adolescent, the even more important this is to give them agency. By giving agency, I mean that you talk to them firsthand. Like many times with children, we end up talking separately to the parent first and then to the child. Here, I would rather give the adolescent agency to describe their problem, to share things with us and give suggestions, be involved in therapy. So first thing is giving them agency. Yes, obviously early intervention or the earliest possible intervention is the best way to go. But while telling that to the adolescent, we need to be very, what to say, careful about it. In the sense, we shouldn't sound like we are telling them to do a certain thing. Okay, we can put it across like it is a choice. There are people who live with their stuttering, and then there are people who try to make it better. And there are two ways to go from here. One way is where it's going to be, your circle is going to be expanding, you're going to face a lot of more people around you, and the more people, the more demands on your communication. So the best way to intervene is now. And when you tell it to them this way, all of them, almost all of them, I'm sure, will say that yes, I want to do it, because that is very important with adolescents. Because the parent cannot be nagging them about, come on, do your therapy, do your practice your techniques, do this task. They have to take the agency, and for that you have to give them the agency. So with adolescents, that is very important, giving an agency, giving a choice, giving them an opportunity to contribute. Okay, and secondly, this sometimes we have to also balance out with keeping parents in the loop. So if I'm talking here about older adolescents, people who are say 15, 16 or 17, many times when they realize that the therapist is giving them agency, they might decide to sort of keep the parent out of things, and that is something which we should definitely not do. So make sure that you're very openly telling the adolescent that suppose I send you a mail about what is to be done, I'm going to copy it to your parents. So at each step, giving them an agency plus keeping the parent in the loop, that balance has to be struck with adolescents. With adults, most of them, almost all of them, have been to a therapist before, have Googled about this before, have tried and tested 100 things before, like Sanjeev sir showed us in the beginning, that they have done all kinds of experiments and come to us with a lot of frustrations, a lot of bitterness. So this is something which we need to acknowledge. And at that point, we need to tell them, I usually tell them three things. First, accept accept that this is a tendency you have, and don't keep that mindset of I want, this is something I want to take out and throw out of myself. It is like spectacles, you have a tendency, you have a visual issue, you wear spectacles and you can see better, but your number is not gone. So your tendency is there, but you can definitely control it if you use the right way, which I'm going to show you. So accept. Second thing is go easy on yourself. Firstly, give yourself credit for what you've achieved and be patient with yourself. Don't be in a hurry to achieve too much in a very short time. And third, be persistent, because speech is not something that can be done once in a while. You have to be persistent and regular with your sessions and regular with your practice. So these are things I feel is important for adolescents and adults.
I just want to add on to what Pallavi has mentioned about different things. First and foremost, like as Pallavi suggested, sir, one thing we need to say to the client is that by adulthood, uh, we are only trying to reduce the impact of stuttering on the individual. There is no way we can cure stuttering in them. It is possible in preschool children, in school-going children. But in adults, adolescents, we can only reduce its effects to minimal level. It's not possible to completely eliminate stuttering. This point needs to be highlighted to them so that, like Pallavi suggested, they need to accept that they are going to live with it. It is not possible, they cannot completely cure. Okay. And like I said, active role of the client is most important. When it comes to treating preschool children, most of the time it's like, we work on the environmental factors, modifying the parental reactions to the child and all those things. But when it comes to adults, we will only be teaching the technique to them. We will be monitoring their disfluencies, but they are the ones who have to put a lot of effort from their side, because they have been stammering from last 10 years, 12 years, 14 years, or 20 years in some cases. So there is this strong established faulty neural networks in the brain. So we need to be, with therapy, we are going to train these faulty neural networks, change them, and to bring in more fluent set of neural networks for fluent speech. So that takes a lot of effort from client side because there are already these established networks are there. So to retrain the new set of networks from their side, a lot of effort has to come. They need to be persistent. That's what Pallavi was highlighting. Like therapy, again, it will be a more structured therapy, unlike preschool children or school-going children, where there is more like a play activities and all those things can be taken up. You need to highlight this to them that therapy will move on in a structured way. You are going to stepwise, you move on from maybe start with if it is severe stuttering, prolonging all the syllables so that he understands, fluent speech is possible without any disfluencies. Then move on to only, first word prolongation, first syllable prolongation, working on the prosody aspects of it, practicing it outside the clinical situation. It's a highly structured therapy. This has to be highlighted, and therapy completes only when all the stages of the program are met, right? So that has to be because they lose their patience. By the time 10 sessions, 15 sessions, it may take minimum 20 sessions in some clients. So they need to be patient about about therapy, about their actively they need to practice. Home practice, lot of home training activities has to be given to them. So they need to be told about them that more you practice these things outside the clinical situation, better, faster improvement will happen. That has to be highlighted to them. So therapy will be both fluency shaping therapy plus cognitive behavior therapy. It's not completely only modify the speech disfluencies, changes in the attitude, increase anxiety. They are part and parcel of stuttering. In almost, I don't think any client would be, without any kind of an anxiety issue or attitude changes when it comes to adulthood. I don't know if seriously that is there is any client who doesn't have any of these things. Most in the majority of the clients will have these issues. We need to tap that in therapy. So that has to be counseled to them. Positive attitudes, reduced anxiety. We need to be working on those kind of things. Um, and uh, so, apart from that, they would have gone to previous therapy, but when they come to you, when you teach the same set of techniques, definitely they will be, bored about, the previous client also has done the same set of things. So we need to counsel them. Therapy techniques will not change from one clinician to another clinician. It will be the same set of techniques, but the kind of practice which is happening from the client side may not be enough for not much of improvement. Counsel them about a relapse of stuttering, need for long-term monitoring of therapy, fluency in adults. All those things need to be highlighted. Uh, Anything else people are missing? Rakesh, Divya.
Okay. Now moving on to second question, sir. Now I am taking you away from a discussion table to our clinic table, and the takeaway answer to one simple question: what causes stuttering? Because parent will ask you, and we find it difficult to explain theories what are given or what we have got to know in our college life. But when we have to answer it out in simple ways, what need to be the answer? What causes stuttering?
So it's a simple answer is that there is predisposed genetic factors
Okay.
when they interact with environmental factors. Uh, that's what causes stuttering. Like there may be two children at home. Both of them may be susceptible to develop stuttering, but only one child develops stuttering, other child doesn't develop stuttering. Just that the kind of environmental factors which were there for the first child may not be there for the second child.
Okay.
So, strong hereditary role is there. For multiple studies, they have found that there are mutations in specific genes which causes changes in the brain mechanisms. the way these basic ganglia networks are functioning. So that is leading to sometimes, breakdowns, especially at the beginning of the sentences. What triggers stuttering in one child when compared to the other child? What kind of child's temperament is there towards those early initial disfluencies? That matters. Parental reactions, parental model to the child. Some triggering factors will be there. Sometimes, like, some child, one of the child, they had a fever, he fell down from the bed. They are all the, emotional trauma and, reduced immunity, that they act like a triggering factors for the development of stuttering. So although, it's easy to say I don't know the answer, it's better, we say this is the way. In most children it will be causing stuttering. Susceptibility plus when it interacts with the environmental factors.
Okay. The second question: How
I
long
would
will
like to
therapy?
add
Yeah,
here
sorry,
that
sorry, ma'am.
in addition to what causes stuttering, we should also highlight does not cause it. Because many times parents have a lot of guilt that have I done something to make this child this way. So we need to make them, like Santhosh sir said, that there are something called triggering factors and some predisposing factors. So in this case, probably there are some changes in the way you can talk to your child, but that does not imply that you have made this child stutter. So what does not cause stuttering also needs to be highlighted with equal emphasis, I think.
Okay, ma'am. Asking the second question: How long will therapy go?
The therapy is, Divya, for preschool children, how long it will take?
Uh, it depends. Like as I said, first, if parents ask me how long it will take, I would tell them based on first when have they come to me. So first time when they came to me, for how many days or months the child has already been stuttering.
Um, for example, if the child is around 5-year-old, he's been
Depends on the
stuttering for
severity of
two
stuttering.
years. Yeah, he's stuttering started by 3 years of age. He's been stuttering for 2 years. What is your answer if there is a stuttering experience of around 2 years?
Sarah, can you repeat your question, please? It
I'm
was
just saying you asked now specifically, like, duration of stuttering experience could be one of the factors, right? How long the child has been stuttering? Hello. Okay. Will come to Rakesh. What is your opinion with regard to school-going children?
Sir, with regarding to school-going children, how long it will take? First, based on the severity. So, if it is around mild stuttering or very mild or mild stuttering, I can say around average of 15 to 17 sessions. If it is very severe, the or severe to very severe, and it may take up to 30 to 40 sessions. On an average, 25 sessions, sir. Weekly thrice, 25 sessions on an average.
Okay.
With regard to adults, in our clinic, like moderate stuttering, severe stuttering, they take therapy up to 30 sessions. Uh, uh, Thrice a week or twice a week, we do here 30 sessions. Because by then they would have already developed that persistent stuttering, highly resistant to treatment, need to do a lot of structured activities. So,
Okay.
along with that, cognitive therapy, Pallavi, we want to highlight about CBT.
Yeah, I mean, like for reducing the core behaviors in a person with severe stuttering, yes, I agree. It will take about 30 sessions or even more than that. But instead of number of sessions with adults, especially, I tell them in terms of the time interval. For example, if they've been stuttering for like 18 years of their life and they have developed so many negative thoughts, feelings, attitudes, and so many issues with participation, I tell them that you need to overall give yourself 6 months to a year to bring about a significant difference or change in yourself. That does not mean that I'm going to be seeing you for that long. Initially, the therapy will go on for like 30, 40 sessions with the core behaviors to make sure that the actual struggle part of it is taken care of. But to take care and change the way you look at communication is going to take that much time, 6 months to a year, and you have to be prepared for that. So when they enter therapy with that in mind, they are much more patient and persistent with themselves, and that definitely makes a difference to prognosis.
Okay. Now I move on to next question. Ma'am, what's your call on group therapy? Let's start with adult cases.
So come again, sir. I didn't get the question again.
Sir, for the group therapy as an option at different age groups.
Okay. Adults, yes, it does work, but at a later stage initially. But I'm a person who believes in one-on-one therapy, and only when it comes to generalization phase or working, that's when we typically move them to group therapy sessions. Otherwise, most of our clients, Satish, they go on one-on-one therapy basis. We don't do group therapy when it comes to straight away. Like as soon as the assessment is done, we don't shift them to group therapy. We work
Yeah, I
on.
agree. As soon as assessment is done, certainly we wouldn't shift them to group therapy because there's no point. They are still getting adjusted to themselves. So, but the group that I had run, I had patients who had maybe from the 6th or the 7th session onwards to even the later sessions of generalization, like Sir said. Because many times we find that the people in the initial sessions who are about, in the process of learning their techniques, get some tips from the others who have probably learned and used their techniques outside. So that also that exchange also helps. So yes, group therapy works, but only alongside individual therapy and only after the patient has been taught the basic techniques for using in speech.
Ma'am, can these session be used as a situation part, like in any situation we call 2 or 3 person and when they talk to each other. So it's not from the therapist point of view that he's explaining all three together, but it's more of interaction between them. Will it not be
Yeah,
helpful?
that we can have small groups like that. In fact, I have had small groups with children, school going children, where usually I do that when both the children or all the three children are at similar levels in terms of severity and in terms of the stage of therapy. So it certainly helps to have them interact with one another. Firstly, they get to know that there is somebody who's like them. Secondly, we can even have fun activities where they, find out each other's somewhere where the other person is lacking in a very healthy way. So it sort of makes them like the activities, and in that process, their camaraderie grows, their confidence grows, and you just be a facilitator to make sure that the session is going in the direction that you wanted it to go.
Okay. Okay. Ma'am, do you see any future of specialized fluency therapy clinic like we have got aphasia clinic, we find audiology clinic specific to vertigo or to cochlear implant? But do you see any future of such type of things in India where we have a specialized fluency therapy clinic and maybe for our coming students who are right now students and they are planning to come down to go for private practice. So, what's your take on this, ma'am?
Sir, do you want to say first?
You are the right person. You are the one who has a specialized clinic. No. So first thing is that then if SLPs need to come out of that the fear with regard to especially private practitioners, because most stuttering adults, there is a lot of high relapse rate is there. They don't. This is what is scenario I had heard 10 years back in US is that they don't pick stuttering clients because they know that there is this insurance company issue. If there is relapse of stuttering, then there will be issues with the insurance. So not many SLPs who are doing fluency therapy in USA. I don't know about Indian scenario. Again, I've heard from some of my friends, they are hesitant to treat adults because of this case, because of high relapse rate. Doesn't work, therapy doesn't help, and all those kind of things are there. Uh, with regard to fluency, if it's sir, if it is possible with vertigo, if it is possible with aphasia, it is possible with fluency also. I don't know why it should not be possible with fluency. Definitely, more than around 5% of children who stutter are there. 1% of the population stutters. So you just imagine there is like we have 100 crore people in India, and so many stuttering individuals are there. Been need a lot of therapies. We can work on that.
So there is other side also, like you said, there are number of people who have got stammering problem, but I see it's other way around. There are number of clinicians who are coming to work. So don't you think that when the number increase, just to keep yourself different from others, they will come up with more focused approach for one particular speech disorder?
Yes, sir. Already my own student has done that. She has opened a clinic at Mysore. Only fluency therapy she does. Only
Okay,
stuttering
okay.
clients she's taking. And Pallavi does that. That's why I wanted Pallavi to step up. And Pallavi's clinic is exclusively for, I don't know if she, but website said sometime back when I checked it, it was fluency, something like that. Yes, Pallavi? I don't know.
Yes, I do believe that there should be a fluency therapy clinic, and the answer lies in the question itself because we're talking about fluency in general and not disfluency only. We are not talking about stuttering only. So we can include patients who stutter, patients who clutter, and people who are not even patients. Like they want to be fluent. That's it. They want to improve their naturalness, their confidence while speaking, their fluency. Fluency is related to speech and language, isn't it? So I think a fluency clinic is something which is the future.
So from metro cities, we can expect these things will come up soon,
Absolutely.
because there are number of professionals, unlike the other cities, smaller cities, because there are limited number of professionals, so they have to take care of all those things. But I think in metro cities, we can expect these changes.
Yes, and we should all work towards it, I think, to get to spread that awareness that we are the people who are trained to work on anyone's fluency, not just disfluency, but fluency.
Okay. Uh, I think partially this question has been answered, that what should be the guidelines for videos to be recorded by family. So I won't repeat this question again because this was earlier already explained. Moving to the next question. I think this was also partially explained, but here my question is, what are the tips and guidelines for school teachers once it comes to generalization? Because any child with a stammering problem spends his 5 to 6 hours in school, and there he get exposure to his peer group, to his teachers and all. So what guidelines we need to give to teachers through our parents, that they pass it on to teachers?
Rakesh, do you want to answer that, please?
Yes, sir. Sir, you said that what are the guidelines that we give it to the parent so that they will speak to the teacher. So here something face validity is important, sir. Most of the time when the information is passed through a parent to a teacher, the effectiveness is reduced. So I will say that please go and give the telephone number or telephone to the teacher, that I will speak with the teacher so that it has been implemented effectively. So this is first point. Second thing is, I wanted the teacher to just monitor, is the child using the therapy technique or not? She doesn't have to say, slow down, speak fast, take your time, no instruction. Just your therapist or your doctor has said something. Are you, please, are you following it? Are you using the therapy technique? If she just monitors the child's usage of the therapy technique is more than enough to reduce the disfluencies also, sir. And generalization will take effectively because the teacher is monitoring. What will happen? I always give this example. Whenever I am working, I'm alone, I might check the YouTube or I might check the WhatsApp. But when my guide Santhosh sir is in the room, I'll be always sitting and working because of his presence. That I will be working. So because of the teacher's monitoring, what will happen? That child will constantly think that I have to use the therapy technique, and that usage across all the situation, across all the person's individuality, it will have a good generalization. Whenever the child is been asked to address the class, or whenever the child is asked to narrate a story, or while talking to a HM, so all those things that teacher has to monitor. And the second thing is, as I already mentioned, teasing, bullying, all those things has to be taken care. And if there is any that openness. The child can approachability of the child towards these sensitive issues towards the teacher should be enhanced. The teacher shouldn't ignore this. And first of all, the teacher shouldn't laugh at the child. Most of the time, unfortunately, what will happen, I don't say everywhere, few of the places, even the teacher will only join the bullying. So that is one of the bad instances that I have come across. So we need to orient the teacher first, then we need to ask him to implement these things. First, we need to orient the teacher. That's why in Aish, every year we call the training teachers before they're deployed for teaching. We call them and we orient detail regarding the referral or identifying or all these instances to the child, to the teacher, so that she implements it effectively.
Sanjeev sir, your mic is muted.
Sorry. What about teletherapy option for stuttering treatment?
Teletherapy, sir, there is no evidence in Indian context, so I don't want to comment on that, saying that it is effective and it is not effective. Until it is, there is evidence. Let us not comment on its efficacy. But it's one of the good things about stuttering is that definitely it can be adapted to telemode also. Unlike I don't recommend any of the child language disorder cases for teletherapy because it's very difficult to manage during teletherapy. But when it comes to adolescents, adults, I mean school-going children, definitely when you work with the child through telemode, we have found during Corona time that it is efficacious. And we also have a telecenter for communication disorders at AISH, where regularly many children and adults, they take therapy through telemode. They are benefiting from therapy, but we don't have any published evidence on that in Indian context. So once that emerges, then only we can say it is working.
Yes.
But there are Australian Stuttering Research Center. There are many published evidences are there on Westpin program, Lidcombe program, Kempodon program, even including CBT. They have now standalone versions of CBT are also available. So they are found to be effective.
Sir, in my personal experience, I will say that maybe I've not done in a standardized way, but I have seen number of cases during the corona, and I can say for many of my patients, it's worked out very well. I'm sorry to say that I don't have any standard format which I would have followed at that particular time. But when I tried this with the school-going children, 14 year of age, and as of now, I am dealing with three adults. But as they are continuing for the third month also, I believe they would have got some positive response that they are able to carry it on for the third month also. So that's my personal experience, sir.
Sir, just one more point adding to Santhosh sir. Everything is ditto here, but during tele-rehabilitation, pause and talk administration of the pause and talk technique could be challenges, sir, because of the
Okay.
network issue. Other techniques can be used, but pause and talk, it requires an eye contact and a clinician should be very quick in asking to stop. But if there is any network delay or if there is anything issues like with the speed of internet, then it could be an issue for pause and talk. Rest, there is no issues, sir.
Okay, sir.
Divya works with a lot of young children. Divya, have you come across teletherapy anytime with young children?
Not really, ma'am. Like personal experience, I haven't given teletherapy for preschoolers, and whatever research evidence is there, most of it is again from Lidcombe, which definitely says it's effective, but then that's a parent delivered program.
Okay,
So,
right.
so
I
the
just have anecdotal. Sorry, you were saying something.
yeah, I mean the actual therapy is happening in person only because parents are the one delivering the treatment there, and that weekly
Right.
clinic visit which the otherwise happens in person is what is happening online through telemode. So
So
I think
it's more of counseling.
yeah, so teletherapy can work only with respect to training parents, or maybe for observation. If you have good internet and you're able to observe parent-child interaction and see how parents are delivering and how the child is using the strategies. but an active clinician involvement for preschool age might be difficult through telemode.
Yeah, I had anecdotal evidence of just 2 cases during the pandemic because there was just no other way for them to come and they were very keen on coming. So, uh, 2 5-year-olds that I saw online. Again, like Divya said, a lot of parent training was involved. The parent was actively involved in the session and I was facilitating it. But there are also, when at that time I had also looked up a lot of these links, these sites which help for teletherapy with younger children. Sorry, it's raining here, so that if there's disturbance, I'm sorry. So there is a site called boomlearning.com. There is a site called storyberries.com, which is, it has pictures where the child can tell a picture story. Boom Learning has games. Then there is another site called abcya.com, which has a lot of games for different grades. So there's, for instance, one activity which I really used a lot that time was building a Christmas tree. So every time the child, it was like while doing token economy, every time the child did something, I was putting a ball on the Christmas tree from my end and the child could see it happen. So the child was choosing what they wanted to put. So it went very well. And in fact, I saw progress in this child in about 6 sessions. So, and it was an early intervention. So the parents were also very happy that the child almost got over his stuttering. So this is just anecdotal evidence, but just wanted to share.
Okay. This question already explained by Dr. Santhosh, so we can just skip it and move on to next. Are there apps available for therapy?
So apps are there. Samurai app is there, which is now most worldwide most popular, developed by our own Indian. There are 2 IIT guys, Meet Singhal and one more person, Amit, some person. They are from IIT Delhi. They have developed this Samurai app, which you can download in a free version as well as a paid version. They both from iOS as well as from Android platforms. You can download that. So that app has both, initially it has its own. I was involved in some of the aspects of development of this app. That's how I know about this app. A little more on this app. So we do have some demographic details and all added to that app where we collect about, because you can't measure severity of stuttering. We have put UTBAs there so that we can document the impact, impact score as well as the meaningful thoughts and beliefs. This one about stuttering. There is also a few more questionnaires we have added there. Initially, some of the modules in the app you can do self kind of a thing, but for some modules you can also request an SLP guidance. Also, there will be an SLP. She will come online and you can work with the SLP also. So this app also has this option for these things also. Currently, they are testing this app. There is one clinical trial going on at AIIMS Delhi. But they are collecting the data from all over the world in trying to see how best to get the best app for stuttering. Apart from these apps, there are few other apps are available. We are doing a systematic review on that. We're using mobile app rating scale. We are trying to document what are different features of this app and the content validity and all those things we are measuring for the apps. So there are apps, definitely. You can go to Android as well as iOS platforms. You can search for these apps. They're available. Some of them are free apps, some of them are paid apps. But again, the efficacy of these apps, I don't know. I've not come across any study on that. How well they help in reducing the sampling.
So now with this, I call upon Mrs. Uh, Disha to go for vote of thanks.
Thank you, sir. First of all, I would like to thank Isha for their approval and constant encouragement, and also Shweta ma'am for their technical support. Going further, I would like to thank Dr. Santhosh sir and accept our token of appreciation. Then I would like to thank Dr. Divya Seth for your very precise lecture, and please accept our token of appreciation. Dr. Rakesh CV and Dr. Pallavi Kelkar for your support and your lectures. Thank you so much. And most importantly, I would like to thank the SIG team for all your time and effort to put up this show. So thank you, everyone. Lastly, I would like to thank all the attendees who have attended the webinar and shown their interest and support in this webinar series. I would like to also request, kindly note the advisor of your respective states and get in touch with us if you have any suggestions for upcoming webinars and any topic if you would like to be taken up. Thank you, everyone.
I also want to thank all the SIG members, especially Sanjeev sir, because I just want to say one thing about Sanjeev sir here. Whatever I have learned about stuttering is mainly from my mentor, Dr. S.R. Savitri, and one of our favorite students was Sanjeev sir. During my initial days of PhD, she used to recommend, you go through Sanjeev sir's dissertation, Anu Subramaniam's dissertation, the kind of work they had done and all those things. So you are one of my, mentors kind of a thing. Then I used to read your dissertation, sir.
Thank you very much, sir. So kind of you, and it's
No,
really
that's a
delight.
fact. That's a fact. That I should mention that because I know I've read your tool which you have developed. I've used your tool for my PhD for measurement of naturalness of speech in for my PhD. And it was. I also want to say that overall the webinar was professionally conducted. We had everybody participating, and Sanjeev sir as giving us all the necessary help and uh, making sure that everything is fine. Every minor things were discussed in the group, and we had. I really enjoyed attending, presenting, and interacting with everyone in this group, this series. I hope that it gets uploaded on the YouTube sooner so that maximum people can get benefit from this.
We are also hoping for the same, sir.
Yeah. Yeah. It's just that we were not sure how it will come out, but I'm very happy the way the end the product has come up. Thank you everyone.
Thank you very much. Okay, thank you.
I think we should gear up for Stuttering Awareness Day also now that October is starting. There's going to be this online conference. So I've put a link also, so it can be shared.